Good morning. Thanks for being here, those of you here. Hope everybody had a good weekend and extra day to recover from the Vikings game this today, unfortunately. But I want to thank our sponsors, AstraZeneca and Boehringer Ingelheim. This is our annual third-year fellows conference. We're actually doing a combination today with both of our third-year fellows. I'll introduce them both, and then they'll give their talks. So first of all, Tareq Al Saadi, he graduated from the Faculty of Medicine of Damascus University in Syria, came to the U.S. for training. He did his internal medicine at University of Illinois Advocate Christ Medical Center, and then came here and has been with us for the last 3 years. He recently passed the very challenging echo boards and as well as the nuclear boards. He'll be going to the community hospital in Munster, Indiana to work as a non-invasive cardiologist. And then Joe Steffens, our other senior fellow, attended med school, University of Washington. He's a native of Montana, did his internal medicine and chief residency both at Hennepin, and he will be joining MHI in United Hospital in St. Paul. And anyways, thanks for being here and look forward to the presentations.
Thank you, Dr. Harris, for the introduction, and thank you guys for tuning in and being here today. I have an interesting case to share with you. And in this case, I actually had the opportunity to see both at Hennepin and at Abbott. So it was a very kind of great learning experience for me. So jumping right in, my patient was 41 years old. He did have a history of HIV. He was compliant with his antiretroviral therapy, so his CD4 count was normal and the viral load was not detected. He was a smoker and he worked as a truck driver. No family history of sudden cardiac death or cardiomyopathy. He did present with syncope, some chest pain. Troponin peaked up at 600. He had some T waves inversions on the EKG, you can see here. Workup initially included ESR and CRB, they were normal. PE was ruled out, aortic dissection was ruled out, and coronary arteries were open with no disease and a calcium score of 0. On his echo, mostly normal. He did have some RV enlargement that was not on the 2D echo, but the LV was normal with normal function and no regional one motion abnormality there. And while he was hospitalized, he got on telemetry, and that showed a few episodes of non-sustained VT. So because of his presentation, his troponin elevation, and his arrhythmia, he got a CMR. So the cardiac MRI actually showed normal LV function and systolic and regional one motion abnormalities. Normal LV function and no regional one motion abnormalities. The RV was a little bit enlarged. Systolic function was a little bit decreased, but there was no regional one motion abnormalities either. He did have some LGE, particularly in the septum, in the basal to mid-septum RV insertion site. As we see here, this is the septum here. So after this MRI, we kind of saw that he has RV function dysfunction. So we thought about ARVC. And I wanted to show you here the diagnostic criteria of ARVC, which is kind of pretty extensive criteria depending on structural abnormalities, electrophysiological abnormalities, and family history and tissue characteristics. And these criteria are from 2010, and there's some diagnostic terminology related with those criteria. And when we tried to apply those criteria on our patient, he actually had 2 major criteria, which is basically T waves inversions and non-sustained VT. He did also have QRS of more than 140 milliseconds. So based on those criteria, we kind of gave him the possible diagnosis of ARVC. And the question became here, would he need an ICD given his presentation of syncope. So the guidelines actually are kind of pretty clear on that. This is from 2019 Heart Rhythm Society guidelines. And you can see here that everything starts and ends with a shared decision-making with the patient, of course. And the guidelines say if the patient had a cardiac arrest or sustained VT that was not hemodynamically tolerated, he would need an ICD. Otherwise, if he has arrhythmogenic cardiomyopathy that's not ARVC, he would for class 1 indication. And if it was ARVC or if there was syncope that's suspected to be due to ventricular arrhythmias, then it would be the class 2A indication. And so on and so forth here. So based on this, and after discussing with the patients, we kind of ended up putting an ICD for primary prevention of sudden cardiac death. And he was discharged home on some beta blockers. He unfortunately had multiple presentations after that with recurrent syncope or recurrent kind of near syncope, PVCs, and non-sustained VT. So at some point, he was also started on amiodarone to suppress his arrhythmias, and his beta blocker dose was increased. Because of his kind of recurrent presentations, we kept thinking about sarcoidosis or other inflammatory disease, just because of the abnormal MRI and the troponin elevation. So a PET scan was ordered, and that was actually done as an outpatient, and it was done at an outside hospital. I don't have the images, unfortunately, but I'll show you the report here, what it showed. And it basically showed abnormal FDG uptake in the basal segments, in the septum, and the inferior and inferior walls. And there was corresponding perfusion in these areas. The PET scan also showed some hypermetabolic cervical lymph nodes. He had had COVID-19 infection a few weeks before the PET scan, so that's what we kind of attributed to. But there was nothing in the mediastinum or the area to suggest sarcoidosis. So at that point, we kind of proceed with biopsies to kind of get more accurate diagnosis here. So he did have cervical lymph node biopsy, and that was reactive tissue negative for granulomas. He also had a myocardial biopsy from the RV. And it did not kind of give us any answers either. Showed some patchy fibrosis, but it was negative for sarcoidosis or any other inflammatory problem. Unfortunately, our patient kept having VTs, and it kind of got worse to a point where he got multiple shocks and actually multiple ATPs. This is kind of a sample of his device interrogation. So an FDG PET was repeated just to kind of see what's going on here, because we don't have the images from the outside hospital, and he kept being very symptomatic. And we can see here on this FDG PET that there is abnormal uptake in the basal segments. Perfusion-wise, it was probably normal. We didn't call any perfusion abnormalities here. So at that point, we were thinking, would this diagnose, or would this be enough to diagnose cardiac sarcoidosis? And here are the diagnostic criteria for cardiac sarcoidosis. It's a 2014 Heart Rhythm Society expert consensus statement. And basically, to diagnose cardiac sarcoidosis, you need to have either tissue diagnosis from the heart muscle, or having extracardiac sarcoidosis with some criteria. And our patient, unfortunately, did not suffice those criteria. However, because of his presentation and the kind of characteristic FDG PET, we gave him the possible diagnosis of cardiac sarcoidosis. And we kind of decided to start him on treatment because he was having lots of ventricular arrhythmias there. A couple of words about treatment for cardiac sarcoidosis. We start with the corticosteroids. Usually, it's the first-line agents. There were some studies repeating high rates of recurrence with monotherapy. Other things we can use are immunomodulators. those medications can be started with the corticosteroids in cases of kind of severe aggressive inflammatory disease or if there is life-threatening arrhythmias. And the third-line agents would be anti-TNF agents like infliximab and adalimumab. So our patients was started right away on prednisone and mycophenolate mofetil. And we started him at the same time on antibiotics as a prophylaxis, nystatin and calcium and vitamin D. And of course, before we started those, we kind of reached out to his ID doctor to kind of make sure that his HIV status is under control. A couple of words about managing arrhythmias with arrhythmogenic cardiomyopathy, which includes sarcoidosis. This is from the 2019 Heart Rhythm Association or Heart Rhythm Society guidelines. And they basically talk about starting antiarrhythmics like amiodarone or sotalol in case of symptomatic arrhythmias. And if you have a preserved RV and LV function, flecainide with beta blockers is an option. And the guidelines also talk about ablation in the resistant cases or if the patients did not tolerate antiarrhythmic therapy. It also has kind of a class 2A indication or 2B. Guidelines from about cardiac sarcoidosis as well also talk about ventricular arrhythmias. And everything is going to here labeled as can be useful. So immunosuppression is kind of indicated in these cases. Antiarrhythmics can be useful. Ablation can be useful. So our patient, unfortunately, kept having arrhythmias. That was actually worsening over time, even after we started the immunosuppression therapy. So this is his FDG PET 5 months after he started the therapy. And we can see, unfortunately, that it's not that much different from where we started 5 months ago. So this is kind of what happened after we got that FDG PET. He kept having arrhythmias. His immunotherapy was up-titrated. And he had kind of switched between multiple antiarrhythmics. He was on amiodarone, then sotalol, then mexaletine, and really nothing worked. He eventually got a PVC and a VT ablation. And in the EP study, they also saw lots of polymorphic BPCs. There were too many to count, or too many to ablate even. So I think he got a couple of those ablated, but he kept having arrhythmias. At the same time, his cardiac function kind of slowly decreased to the 30% of the LVEF. And at that time, the third-line agents that we talked about, Humira or adalimumab, was started. And because he kept having arrhythmias, he was considered for transplant at that point. A couple of words about transplant in HIV patients. The HIV infection has still being considered as a relative contraindication for transplant in most centers. And that's because of kind of multiple reasons. I'm going to want to kind of list a few of them. The HIV positive patients are perceived as a high-risk patients, and they are avoided given the scarce organ supply. There is also a concern that the immunosuppression might worsen the HIV status and kind of progress it to AIDS. And there is also a concern for drug interaction with the immunosuppressants. We have some data from the kidney transplant patients who have HIV status, positive status. And that data showed that HIV patients remain stable post-transplant on immunosuppressants. And however, the data also showed that those patients will have higher rates of rejection, which can be partially explained by the drug interaction between the immunosuppressants and the antiretroviral therapy. This is a nice study published in 2021 about kind of survival of after heart transplant, comparing HIV positive and negative patients. And you can see here that there's like really no difference in survival. So our patient eventually got admitted for recurrent VT, requiring multiple shocks and ATP. He was listed for a transplant and eventually got transplanted. He did have kind of a rough post-op course because he had a cardiac tamponade requiring return to the OR. He did have pericarditis after he got discharged, and he unfortunately also had acute rejection. But he did well with medical therapy. So we sent the heart for pathology to see what will the diagnosis or what's going on with the heart. And I have some pictures here from his pathology report. The first is that we have dilation in both ventricles and fibrofatty replacement. You can see here the thinning of the RV. There was a band-like fibrosis in the ventricular septum. And in both RV and LV, there was myocyte degenerations and fibrofatty replacement. And this is both RV and LV. There was no evidence for cardiac sarcoidosis, no granulomas, no inflammation. So at this point, I kind of retrospectively asked a few questions for myself, and I was kind of able to find some evidence in the literature about why we saw inflammation on his PET scan. So the first question I asked myself is, how sensitive and specific is FDG PET for cardiac sarcoidosis? This is a nice systematic review, kind of pulling the results from studies looking at this. And we have a sensitivity of 84% and specificity of 83% for cardiac sarcoidosis. So really the PET scan is not that sensitive or specific. It's more of another information that we put into like a general picture. And it's not enough to diagnose cardiac sarcoidosis. How commonly we see positive FDGs in patients with ARVC? There aren't many data around this, about this in the literature. This is one study that I found was also retrospective. In this study, they kind of took all the patients who are diagnosed with ARVC, precisely 16 patients, and 7 of them had positive PET scan. So that's kind of a high ratio there. And interestingly, 2 of those 7 ended up having sarcoidosis on myocardial biopsy. So it's not that uncommon to see inflammation or positive FDG PET in patients with ARVC. This is another study, but it's done on patients with left-sided cardiomyopathy. They excluded patients with sarcoidosis or patients with ARVC. And this is also a retrospective study. And they looked at all the patients who have that diagnosis, and they saw who got next-generation sequencing for pathologic variant or likely pathologic variants. And they also looked at everybody who got biopsy. And they classified patients based on having acute myocardial inflammation on the biopsy. So you can see here 50% or more than 50% of those patients had evidence of inflammation in their biopsy, which is kind of really a high percentage here. This diagram kind of classifies patients based on their genetic status and based on their inflammation on the biopsy. And we can see here that there are some patients who have both positive genetics and positive inflammation, and patients who have neither, and patients in between as well. And the authors kind of found that having inflammation actually worsens outcome in terms of MACE at 60 months. The last question I asked myself is, where does inflammation fall in the pathogenesis of arrhythmogenic cardiomyopathy? This diagram is from a very interesting review about arrhythmogenic cardiomyopathy published in 2021. And the author here hypothesized that we would always kind of have pathogenic variant on genetics, that in the right environmental factors, including strenuous activity or infection or immune agents, it triggers myocardial damage and necrosis. And that myocardial damage and necrosis is followed by inflammation, which later leads to the extensive replacement type fibrosis that we see on the biopsies for those patients. So there is an inflammatory phase in the pathogenesis here that we might be catching on the PET scan. So we don't know exactly what happened, but all these are kind of hypotheses that are kind of very interesting, and they have basis from what we know from the data that's also very scarce and rare. That's everything I got. Thank you.
Nice job, Tareq. Their MRI was really more consistent with the arrhythmogenic, right? Can you speak about that, or maybe show those pictures again now that we know the...
Exactly. So let me just go back here. So the MRI did have, this LGE deposits in the septum and the RV insertion site, which is not specific for a specific a disease, but it's definitely not consistent with the RVC. So the RVC criteria, includes RV issues that I can actually look at here. Like RV regional emotional abnormalities, akinesis, dyskinesis, which we did not see. So yeah, I mean, the MRI basically was kind of non-diagnostic. It showed abnormalities, but it didn't kind of rule in or rule out much.
Did you happen to know his history of HIV, if he had carried it for a long period of time and had CD4 counts less than 100, where quite a few of them will develop inflammatory cardiomyopathies, and he might have been quite a bit further down the line?
Could be. Honestly, I didn't look in his history before we can he presented for cardiac stuff. I thought he had pretty controlled HIV, but I'm not sure exactly for how long it had been going on, or if it was uncontrolled at some point and then got controlled. So that could be actually the reason, or it could be that his HIV kind of triggered. Going back to the last diagram here, his HIV may have triggered some genetic basis for cardiomyopathy. That's also possible, but we can never know. All right. Thank you.
Hey, it's working. All right. Well, good morning, everybody. Thank you, Dr. Harris, for that really kind introduction, and I'm really happy to be here. And I just wanted to let me just pull up my presentation here really quick. It's loading here. I just wanted to point out and thank Dr. Ron Johansson, who's with us today. I'm just really delighted that you're here, and I've known him since residency, and we've worked on projects actually in Thailand and in Laos, and I had the privilege and the honor to go to Kenya with him for this, what I'm about to present today. And we just got back last week, so I'm finishing my last dose of malaria prophylaxis today. So we did make it back. There's some flight changes, what we got here. So, all right, so let's get started. So my disclosure, I have no financial disclosure or conflicts of interest with this presentation. Any photos of the patients used in this presentation were used with permission and are for teaching purposes only. And for the most part, it's de-identified, so shouldn't be an issue. So a little bit of background here about Kenya. So Kenya they gained independence from Great Britain in 1963. The population's about 53.1 million. And the official languages are Swahili and English. And I don't know if you can see my cursor here, but where we were is Eldoret here mainly, is in western Kenya. And then just kind of north by northeast is Kapsawar. Not on this map, but that was the other hospital and town that we went to. So And this is in Eastern Africa here. So in terms of epidemiology, life expectancy is 67.7 years. The median age is about 20 years. The prevalence of rheumatic heart disease in Eastern Africa is about 15%, okay? And to give you kind of an idea, about 300 to 400,000 deaths occur worldwide due to rheumatic heart disease, and the vast majority are women. And common ages are in the second and third decade of life and in pregnancy. It's also likely that this number is underestimated because a lot of times patients will come in with complications from rheumatic heart disease, or they're not identified or not treated, and pass away from either a stroke or other thromboembolic events, and those are kind of marked down as the cause of death. So just to give you an idea of where that number is. And so in terms of the causes of death in Kenya, this is World Health Organization data. So neonatal conditions are the highest cause of death. And I do want to kind of point out that ischemic heart disease is at the bottom. So anecdotally, the patients we took care of over in Kenya, a lot of them were teenagers, 20-year-olds, 30-year-olds, and I only saw one patient with ischemic heart disease. So that was a very different paradigm for me compared to what we treat here in the US. And so you really have to come at it with a very different lens, and it's a different setting for sure. And then here's the United States, so ischemic heart disease is at the top. So as you can see, very different burdens of disease. So part of our project was to do a lot of teaching, and so that was giving lectures, joining on bedside rounds, and also teaching ultrasound. So this photo on the left here, this is in Eldoret. This is in the CCU, the cardiac care unit. This is Dr. Kiang here next to me, and I worked with her most closely. She's the staff cardiologist there, one of the staff cardiologists there. And then on the right here, this is in Capsoar in one of the medical wards. And so we're going over some bedside cardiac ultrasound there with the team. And then here's another kind of picture of the theater where the valvuloplasties and the CV surgeries were performed. There was a CV surgery team there as well while we were there. So this is the photo on the left here in Eldoret. And then the photo on the right is the hospital in Capsoar, which it's literally on a hill, and there's like multiple kind of levels that you have to walk and hike up to. And so this is kind of near the entrance there. Okay, so in terms of rheumatic heart disease screening, so what counts as saying, hey, this patient's got pathologic MR. So I did want to kind of go over these criteria with you. So these are from the World Heart Federation, and they were just released actually like August of this year. So hot off the press here. And so really focus on kind of this upper box here. So with the quick POCUS, what we're really looking for is the jet of mitral regurgitation, okay? Pan-systolic velocity greater than 3 meters per second. And then based on the weight, if it's 1.5 centimeters or greater, or if it's 2 centimeters for patients weighing over 30 kilograms, we say, hey, that's a positive echo for rheumatic heart disease, valvular heart disease. And so to give you an example of a screen, so this was in Capsoar, so a 12-year-old patient presents with his father to get his echo. They're in the ultrasound room together. And here's what we see right away in parasternal lung, okay? So really good leaflet motion. Nothing's really remarkable here. Good wall thickness, good systolic function. We throw some color on there, and you can see here there's a little posterior jet of mitral regurgitation. And so kind of our next step here is let's measure that jet and kind of make a decision here if we're calling this a positive study. Just to show you this in another view. And so here we measured it at 1.07. And so by the World Heart Federation criteria, this would technically be a negative study because we're looking for 1.5. But one thing that Dr. Johansson had worked on and studied is actually using a cutoff of 1 centimeter to call these positive, just because unfortunately you kind of lose a lot of the positive studies depending on the nature of the jet. And so part of why that jet was less than 1.5 centimeters is it's very posterior oriented and going into the atrial wall. And so we did call this a positive study. And so the next step is to get the patient on some penicillin. And so One thing they are able to do is do gluteal injections of penicillin, so monthly gluteal injections. And so we counseled the patient, talked to him and his father, and got him started on those, which we're hoping he gets at least until the age of 21, potentially longer, depending on how his course goes. A lot of the guidelines base your treatment course and your length on when their course of rheumatic fever was, but we don't always know when that is. You know, it's like, hey, when's the last time you had a fever? What were your symptoms? It's pretty difficult to ascertain that. And so we kind of default to longer treatment courses if we can. And so here are the ACC/AHA guidelines for when we identify patients who have pretty severe mitral stenosis or moderate to severe. And so occasionally we'll catch this on a screen, or a patient we're following you know, is starting to present with really significant symptoms, and it's time to intervene on the valve. A lot of our patients kind of fall into this category here: severe MS with no clot, and kind of go down one of these two pathways here. So either they're asymptomatic exertional, or they have significant MR with their echoes as well. And so Wilkins score, just a quick refresher here. So it's a qualitative assessment of the mitral valve when you identify rheumatic heart disease. What we're looking for is a score of 8 or less. Is kind of a favorable, kind of favors doing a balloon angioplasty versus replacing the valve altogether. And so you basically, you know, use these criteria and add up the grades to get your score. So
Joseph, can I
yeah, please.
because it's kind of important.
Yeah, go ahead.
If you have a Wilkins score of 8 or less, your acute result tends to be quite good, and the durability tends to be quite good. 7 out of 10, 10 years later, are just as good when you first fix them. But what the classic Wilkins score doesn't have there is plus looking at, as you well know, because you looked at so many with me, the mitral valve in the peristernal short axis view, and making sure you can clearly see a commissure that you can split. It's a contraindication to try to do it if you have fibrosis all the way around the commissure ends.
Thank you. And so I'm going to shift gears here and move into a case of a patient who's got known rheumatic disease and has been having worsening shortness of breath, and has been having some weight loss as well. He's been medically managed with metoprolol, furosemide, and spironolactone, but his symptoms are quite significant. And so he came in, and here is his transesophageal echo, just to give you an idea of kind of what his mitral valve looks like here, and the mid-esophageal view, commissural view here. A lot of these patients do have atrial fibrillation. This patient did not, but that is also something we'll see. His patients in their 20s with AFib. Here's the gradient on his mitral valve, so a mean of 16.5. And I do want to point out this is while he's sedated and intubated, and so it's likely higher in his kind of day-to-day and when he exerts himself as well. And so here's kind of long axis here showing that there's also associated aortic insufficiency. Rheumatic disease affects the aortic valve as well. Some more views here, and we see that kind of, you know, in Kenya we would say the dog leg deformity, but in Minnesota we say the hockey stick deformity. So I think if I said hockey stick in Kenya, I'd get some weird looks, but you can clearly see it here. This is kind of what you see. And so here's a clip of the transseptal puncture, an example of one. And so, you know, when you're doing transesophageal echo for these procedures, kind of the two really important views are the bicaval view and the short axis of the aorta view, and kind of going in between those frequently, so the operator knows where they are with their needle, and you know, obviously don't want to go too anterior and hit the aorta, and you also don't want to go too posterior. And so here's kind of an example of a good spot to do your transeptal puncture. So it's just a little posterior to the fossa ovalis there. And so pushes through. Okay, and then here's, this is our patient, so after transeptal puncture, and here's the balloon and the valve, so ballooning up and opening up that valve. And one of the things we really look for after this is degree of mitral regurgitation, which is pretty, commonly occurs after you balloon open a valve. And so here's what it looks like on fluoro. So the balloon does have some contrast in it that you can see on fluoro here, and there's the TEE probe as well. And then here's what it looked like after his intervention. So you can see a little bit of MR now. So, and then we measure the gradient as well. And his mean gradient now is 5. So pretty good result. And then here's the next morning, definitely better leaflet mobility. And he was feeling better the next morning as well, at least at rest. He wasn't exerting himself when we saw him. But and then here's kind of apical view of that valve too. So and just another view when we checked it, got the same mean gradient there too. So and then that was a good segue what Dr. Johansson said, kind of about the durability and length of effectiveness of mitral balloon valvuloplasty. So a couple studies are discussed here, but our rates at about 31 to 39%. It looks like kind of at 7 years and greater, and so pretty good durability to get them through kind of teenage years at least, and then should be followed after that as well with symptoms too. Okay, so second case. This was a case, I believe it was on our last day or maybe second to last day there. So this was a woman who had actually come to the hospital to schedule an appointment. And she had been very symptomatic and she couldn't even walk on any type of hill or incline. And on flat ground, she couldn't walk very far, but she was able to ambulate short distances on flat ground. Someone had noticed her at the appointment and said, "Hey, you should get an echo." And we happened to be doing screens that day, and so she was brought over to the area where we were doing some screens, and she got an echo. And also of note, her father did recently pass away from rheumatic heart disease. I think it was within the last year or so. And this is kind of what we were able to get in the screening clinic. So her mean gradient was 15, so certainly severe mitral stenosis. And so we talked to her. We said, "Hey, we should open this valve up," and came up with a plan, and were able to get it done. She was admitted overnight and volume optimized. She was a little volume up, so she got diuresed and started on a beta blocker. And then we did her case the following morning. And her mean gradient improved to 4, and she didn't have any mitral regurgitation after that. And so it's kind of in disbelief right after, after it happened, the mean gradient was 4, and I checked it in like multiple views and couldn't get higher than 4. And then we did check her bedside echo the following morning, and it was at 4 as well. And so that was a good kind of a good case and a good example of catching someone with the screening echo, and well, she was symptomatic, but catching someone with an echo and intervening and helping her out. So yeah, so those are kind of some of the cases that we did. I think ended up doing 14 valvuloplasty cases the 2 weeks there, and then helping out in Capsuar. They don't have a ability to do valvuloplasties in Capsuar. That was more bedside echo and screening and helping with medications and things up there. But yeah, so I want to say thank you to everybody. It was a really good experience. On the left there is in Capsuar, and then on the right is in Eldoret there. And so, and then here's some other pictures. So, yeah. Any questions?
Do you routinely anticoagulate after PBNB?
Yeah, we did. Yeah. Mm-hmm.
For how long?
Yeah, so I think we were doing 3 months. It depends if they had AFib or not, but at least for 3 months. And then we would check and make sure it was not blocked or anything.
Great job, Joe, and thanks for doing that. I'd also like to acknowledge Ron Johansson, who's here in the audience and has been a mentor for many of our fellows who have done this global health elective. I think, if I'm counting right, this Joe is our 6th fellow to take advantage of this opportunity we have, and I know definitely one of our incoming fellows has a strong interest in this as well. So 2 questions. So first of all, how are patients recruited to the, for your screening process? And then 2, can you maybe let us know a little bit more about what you do? I mean, I can read an echo, but I don't really have any other skill sets. And so how does that work, in the evaluation? Like what did you do exactly?
Yeah, so, and Dr. Hansen, please add to this too. So the first question, there's a lot of community engagement, which, Dr. Hansen's been to this site many, many, many times, and I did notice it right away when I was there. From nurses in the community, family members in the community, for the screening process, the schools will typically dedicate a day for screening. There weren't any school screening days while we were there, unfortunately, because it was exam time. So it was, in November, early December. And so it was more of a kind of case by case, the screens that we did, and then also kind of random sampling in the hospital that last day where we were able to catch that last patient. If you want to talk about the details of the time, I know you do hundreds of kids in a day pretty easily when there's a dedicated school screening day. If you wanted to touch on that, yeah.
We have programs going to pick them up very early in Ethiopia, 2 spots in Kenya, where over 20,000 kids now. Good cooperation of the local ministers of education, local political people that want to kind of slip in on this good effort. And in the one article you showed, we do a method where we do a 60-second screen. And when we do the math on that, if you go to a boarding school of 400 children, and you do a 5-minute screen, which would seem pretty reasonable, that takes 32 hours. If you do a 60-second screen, you can do it in 6.8 hours. My math is right there. And then you can still play football with the kids in MT. So then if you extrapolate that to trying to screen 100,000 children in the district, in that area of that endemic area in East Africa, we see about 3.5% positives that we pick up. And the challenge is closing the loop with penicillin. We don't do screening in areas unless we're very successful with the penicillin. Now, to answer the question about the really sick ones coming in, they self-present. This is our 4th trip there, and the first time through, we might be talking about, well, do you think this is a good case or not? Second time through, everyone they show me is a good case. 3rd time through, they're doing almost the whole procedure on their own. 4th time through, they're doing 95% of the procedure on their own. We're working ourselves out of a job, essentially, at multiple sites. So hopefully this year we'll have 3 sites across Kenya and then 1 in southern Ethiopia that can reach a lot of people.
And what could regular cardiologists do to help with or can other people get involved in your program?
My title at Hampton County Medical Center is a Director of International Cardiology. Sounds really important, doesn't it? It's on the letterhead, but they don't bother me with any of those pesky paychecks once I left the cath lab. So we have medicine residents that go with us. We've probably had about 25 medicine residents. And some things that are so vitally important will go to a hospital like Capsuar, where it's less sophisticated, and there'll be young docs there, and they'll come up. I'd like you to look at a patient with heart failure. Well, is it right-sided or left-sided? And kind of working it through HFpEF, HFrEF, valvular, etc. The basic teaching the good use of antihypertensive drugs, there's no end with what you can do. I waste, quote unquote, 2 hours in the cath lab where I might be better applying myself, teaching the young doctors there good cardiology. So there's a ton of opportunity.
Any questions?
No.
Okay.
Thank you.
Well, excellent. Have a good week.